Good morning. It's great to be part of this again this year. I'm going to jump right into it. I actually like to talk a lot, so I have way more slides than 15 minutes, so I'm going to rush through them as fast as I can, but be as clear as I can. Just so quickly, because I'm the first speaker, I know that you all know a lot about melanoma, but just to go over a little bit of the epidemiology, melanoma is the most serious form of skin cancer. There was about 86,000 new melanomas per year diagnosed in the United States, a slightly higher predominance in men than women, 52,000 versus 34,000. Close to 10,000 people are expected to die of melanoma per year, again, a slightly higher predominance of men. The scary part is that the incidence of melanoma is rising dramatically at a rate of approximately 3% per year. And this has been consistent for many years now. And this is despite efforts at screening, mortality has not decreased. So mortality is rising with the number of cases that are rising. And the increased incidence is observed in both sexes and in all ages, including children. So unfortunately, the pediatric population is also seeing a 3% increase per year in melanoma. It's still rare, but oftentimes they could be found a little bit later, and outcomes are the same. So the nice thing about melanoma compared to some of the other cancers is here you can see the overwhelming majority of melanomas are identified as localized. And then so approximately 80% are identified as localized, and then another 10% are regional, meaning it's gotten to the lymph nodes, but it has not spread elsewhere. Only a very small percentage of the patients that present to us with melanoma have distant disease. So usually regional therapies, usually localized treatments, which is the surgical treatment, can cure this disease process. So what are the goals of surgery? So we want to obtain histologic confirmation that the lump or pigmented lesion that you have on your skin is truly melanoma versus some of the other skin cancers. And then we want a complete and accurate microstaging of the primary tumor. We want appropriate margins to make sure that the local recurrence rate is in the low single digits. And then we want a functional outcome, and we want it to be pretty. We want it to be cosmetically appealing. And then depending on staging of the primary tumor, that's when we'll decide whether or not to get lymph node evaluation. So when you present to either your primary care doctor, your dermatologist, or your surgeon, what they'll usually do is you'll identify this pigmented lesion. And just to be clear, over 50% of melanomas are identified by the patient, not by the physician. So don't be scared to go to your physician and say to them, hey, I'm worried about this mole. There's something about that mole to you that is causing you to want it to be biopsied, so be forthcoming with your physician. So when we see these things, what we want to do is we want to get a 1 to 2 millimeter margin on the primary lesion if the lesion is small. We want to go deep enough to get below the tumor, and then we want it, when we do our biopsies, we want it in a direction in usually the extremity or on the torso where I can, if I need to go back and do a wider margin, I can get a primary closure easily. If the lesion is a little bit larger, then oftentimes you can proceed with a punch biopsy, which is a circular razor blade, and we can numb up the lesion, and we can take a portion of the lesion. Usually what we're looking for is the thickest part of the lesion, and send that to the pathologist to give us whether or not it's melanoma and what the depth of the primary tumor is. It's nice if you can get it at the margin of normal skin versus pigmented skin or lesion, but in the center of the lesion is fine as well. Now, unfortunately, many of these lesions are shave biopsied. Now, if you think about what the dermatologist does, the dermatologist sees 40, 50 patients a day, and the overwhelming vast majority of those that get shave biopsies are not melanoma. So this is their normal tool to take care of skin lesions. When they identify a melanoma, it's usually in retrospect. So they do a shave biopsy. The problem with shave biopsies for us is sometimes if they don't get underneath the tumor, then we don't necessarily know the depth of the tumor, and it could be hard for us to figure out what's the next step for that tumor. Now, shave biopsies, we prefer not to have shave biopsies on these lesions, but if it's done, it's okay. We'll still take care of it. So when we get the pathology report back from any of these biopsies, whether it's a punch biopsy or an excisional biopsy or a shave biopsy, we get lots and lots of words on a page. So I'm just a dumb surgeon, so I want to look for 4 specific things when I look at this. I want to look is yes or no, is it melanoma? I want to look at what the depth of the melanoma is. I want to see whether or not there's mitoses in the melanoma, and I want to see whether or not there's ulceration of that melanoma. If it's a thinner melanoma, I'm looking for that ulceration and mitoses because they can oftentimes upstage the tumor and therefore have a higher risk of lymph node metastases, and therefore I'll have a lower threshold to go looking for the lymph nodes. If it's a deeper melanoma, then whether or not there's ulceration or mitoses, I'm still going to do the sentinel lymph node biopsy. Once we've identified that it is a melanoma, our next step is a wide local excision, or a resection of that primary tumor with a wide enough margin to decrease the likelihood of that coming back locally to low single digits. So the excision has to be down to the deep fascia, but we don't need to go through the fascia, we don't need to go into the muscle. So it's really just a skin and fat resection. So functionally, your muscle should be perfectly fine. We want the width of the margins around the lesion to be wide enough that it's not going to come back locally, and that's defined by the depth of the primary lesion. And I'll go into the next slide and show you what those margins are. Over time, in the past, what we used to do as surgeons is we always thought wider was better. So when somebody came with a melanoma, we've decided that 5-centimeter circumferential margins was the best way to do it, because therefore there's no way it's going to come back because we went really, really wide. The problem with that is that's at least a 10-centimeter circular defect. That's very, very, very hard to get primary skin closure. So almost all of those were closed with a skin graft in the past. But many great institutions have done research looking at margins. Is 3 as good as 5? Is 2 as good as 4? Is 1 as good as 3? So what we came up with over many multiple randomized controlled trials, and here is the NCCN guidelines on width of resection based on primary tumor site. So if it's an in situ melanoma, somewhere between a 0.5 to 1 centimeter margin is fine. If it's 1 millimeter in depth or less, a 1 centimeter margin is fine. If it's 2 millimeters or greater in depth, a 2 centimeter margin is fine. You don't need to go any greater than 2 centimeter margins because it's not going to decrease the local recurrence rate. Once you have a very, very deep melanoma, oftentimes our biggest fear is distant metastases, not necessarily local metastases. Now, in between a 1 and 2 millimeter in depth tumor, we have a little bit of leeway. We can go somewhere between a 1 centimeter to 2 centimeter margin because the difference is only about a 3% local recurrence rate. So if the primary lesion, a 1.8 millimeter in depth melanoma, is in an area that doesn't have a lot of skin, and it's going to be very hard for me to get the primary area back together, I can err back towards a 1 centimeter margin to avoid some type of major rotational flap or skin graft. Once we've taken care of the primary area and local recurrence should be less than single-digit percentages, then we need to decide whether or not to go looking for regional lymph nodes. So regional lymph node evaluation is usually based on depth of the primary tumor. The reason we want to look at lymph nodes is melanoma often metastasizes through the lymph nodes, through the lymphatics. And accurate staging at diagnosis is important to assess prognosis. The lymph node status is the most important prognostic indicator in whether or not your tumor is going to come back. Usually we need to know lymph node status to enroll you in a clinical trial. Most trials that we have are either for very thick or worrisome primary tumors or disease processes that have already gotten to the lymph nodes. Physical examination is not an accurate tool for lymph node status. Oftentimes, in 20% of the time, if I palpate a lymph node, there's no melanoma in it. Or 20% of the time, I can't palpate the lymph nodes, but if I do a sentinel lymph node biopsy, there'll be tumor cells, microscopic tumor cells in it. So Dr. Sappi, back in 1874, identified that there was a relatively orderly drainage pattern of lymphatics. And so in a particular area of skin, you can kind of get a sense of which lymph nodes this area is going to drain to. The first lymph node is an effective filter of tumor cells. That doesn't necessarily mean that the lymph node grabs all the tumor cells and stops it from spreading. It just means that if the tumor cells are going to spread, a couple of them are going to get stuck in the lymph node, and those are going to be the ones that we're looking for. If the first lymph node is negative, the entire basin should be free, because usually that's the first lymph node or the sentinel lymph node, so it usually goes through that first one before going out to the others. And the technique of sentinel lymph node biopsy was created at John Wayne Institute in California. So what we do, so there's a couple of different ways of doing it. So one is injecting blue dye. You can inject just blue dots with right around the primary tumor, and then that blue dye goes through the lymphatics. So then when we go into the lymph node basins that we would expect this to drain, we can look for that blue dye, and we can take out the blue lymph nodes. The other way of doing it, which is the way that I depend mostly on, is radioactive dye. So there's no color to it. This is just radioactive. It's injected in radiology, and then they create a lymphoscintigraphy, which is a mapping to show where it goes. And then in the operating room, I use a Geiger counter to identify that radioactive lymph node and take out that lymph node. So here what you can see is they injected the dye right around the primary site. This happened to be in the mid-back. And you can see it traveling along the lymphatics to both the left and the right axillary lymph nodes. And this tells me I need to get sentinel lymph nodes from both axillas at the time of doing the wide local excision on the back. That's my neoprobe or Geiger counter. And that's my incision in the axilla after I've removed those lymph nodes. So the initial studies looking at sentinel lymph node biopsy, what they did was they did the technique I just described and then immediately removed all of the lymph nodes. And they looked at the sentinel and they looked at the background other lymph nodes. And they looked to see the rate of sentinel lymph node positivity and the rate that the sentinel lymph node was negative and the background lymph nodes were positive. They were able to identify lymph nodes in 75 to 90% of cases, but now we're 100%. And the sentinel lymph node being negative with the background lymph nodes being positive was 1 to 2% of patients. So it was incredibly rare. So the sentinel lymph node is very sensitive to identify those melanoma cells. What's the likelihood of my tumor going to the lymph nodes? We usually do we think of it as around 10 times depth. So if you have a 2 millimeter in depth melanoma, it's about a 20% chance of being positive in your lymph nodes. Now, in 2012, the Society of Surgical Oncology and the American Society of Clinical Oncology, which is the medical oncology group, got together and tried to make standard guidelines as to who gets sentinel lymph node biopsies. So what they said is anybody between 1 and 4 millimeters in depth should get a sentinel lymph node biopsy. If it's a thin melanoma, but it has high-risk features, things like ulceration or mitoses, then that upstages the likelihood that the lymph node is going to be positive, and therefore even thinner melanomas with those worrisome features should still get a sentinel lymph node biopsy. For thick melanomas, for prognostic purposes, it's very useful, but very thin melanomas with no worrisome features, you don't necessarily have to do a sentinel lymph node biopsy. With that being said, once the sentinel lymph node biopsy was identified, if it was positive, they then recommended a completion axillary lymph node dissection. This was based on data from a trial looking at subgroup analyses that maybe there was a small portion of patients that would benefit from overall survival if we went back and cleared those lymph nodes. Now, a lot of this was kind of based on the Halstead theory, which is an older theory of thinking that things spread in a stepwise fashion. They go from primary to lymph node, then lymph node elsewhere. And if we can get ahead of that lymph node spread, then we can thinking that we can get ahead of the disease process. But here at the University of Pittsburgh, Bernard Fisher and the NSABP trials looked at different disease processes, including colon cancer and breast cancer, and now we've extrapolated it to melanoma, that it's more likely that when a tumor decides it's going to spread, it spreads like buckshot. So it goes through the lymphatics to the lymph node, but it can also go 16 other places at the same time. And we're using the lymph node just as an indicator as to whether or not it has the ability to spread, and therefore trying to get ahead of it surgically is just going to mutilate or injure a patient and not necessarily help them with an overall survival. So then the medical community went on to do this MSLT2 trial looking at whether or not patients with sentinel lymph node positive disease really actually needed a completion lymph node dissection. So they took about 2,000 patients, and if you had a sentinel lymph node positive disease, and they put you in two arms, either you got a completion lymph node dissection or you didn't get a completion lymph node dissection. They just watched you closely with serial ultrasounds of the lymph node basin. And what they identified was that there was no difference in the melanoma-specific survival. There was a slightly higher likelihood of it coming back in the lymph node basin because the lymph nodes were still there, but if you were under surveillance, then we could then take you to the operating room and clear that area if it comes back. So we've now, and this was in all different subgroups. So we've now gone away from doing completion lymph node dissections in patients that have sentinel lymph node positive disease, specifically microscopically sentinel lymph node positive disease, because we have such wonderful adjuvant therapy that it's better to get you onto adjuvant therapy than it is to try and put you through another surgery. So the conclusion to my talk is that all suspicious lesions should be biopsied. The primary site of melanoma should be resected with margins that decrease local recurrence rates close to 0. Sentinel lymph node biopsy should be performed on anyone with a melanoma greater than 0.8 millimeters in thickness or thinner if it has worrisome features. If the sentinel lymph node is positive, the patient is a candidate for adjuvant therapy, and that should be discussed with your medical oncologist. And completion lymph node surgery is not indicated in patients willing to follow up closely with serial ultrasounds and physical examinations. Thank you very much.